hello everybody. Thank you so much for coming. Pre-COVID, I feel like we're gonna have this separation of pre-COVID versus post-COVID life. Well, post-ish, I guess. Before we had the shutdown, we used to do these workshops a lot. And now my husband and I have tried to navigate how to do these workshops. We're doing a couple online, but we think that it's really helpful to have the in-person component. So I'm glad to see you guys here in the clinic, even though we are a smaller group. That's okay. It makes it more intimate. We get to have a little bit more conversation. And welcome to the people at home or those who are listening to the recording. My name is Christina Previtt. I'm a registered physiotherapist. I'm a doctoral candidate with the School of Rehabilitation Science at McMaster, and I'm one of the owners of this facility. A little bit about me. I graduated from physio school in 2013, so I'm about 7 years out for school, and I'm in my final year of my PhD, which I started in 2015 part-time. My doctoral work looks at the use of exercise with older adults, fitting for this topic. And our business model is very loosely kind of translated from what my research in older adults and exercise has taught me. So I work with arthritis a lot, especially in my practice. I tend to work almost primarily with individuals with arthritis. It's so common, and I tend to like working with individuals between 60 and 85. So yeah, so if you guys have any questions as we go, especially as a small group, I hope that you guys raise your hand and just let me know. And then we can have a conversation. That's part of the beauty of a smaller group. On this presentation, this has been presented with Kelsey and Maura, who are my other two full-time therapists who do a lot of work with individuals who are dealing with pain from arthritis. So they've contributed to this as well. You can be my slide mover.
Yep. Oh, sure.
Excellent. Okay. So before we can talk about arthritis, we need to talk about overarching themes when it comes to arthritis. And I really like comparing arthritis to an iceberg. And the reason why is because we don't wake up one morning and have severe arthritis. That's just not the way that it works. We don't all of a sudden lose all of this joint space. It's very blurry now.
Yep, I'll fix it. Just give me a second. Fixed.
All right. Yeah, it's not fixed. You need glasses. Okay. I can't read it though. So we don't just wake up one day with arthritis. This is something that accumulates over time. As we get older, we have a decline in the amount of joint space that we have in all of the joints in our body. It just happens with, unfortunately, the act of gravity on us. It's the reason why we get shorter as we get older, is that we lose space in between the discs in our spine, which is also a form of arthritis. And so oftentimes there are issues that have been happening with arthritis that have been happening below the surface before it breaks the surface of the water and we start experiencing pain. What that also means though is that with moderate to severe arthritis, you don't necessarily need to have pain. You can have that really damaging term bone-on-bone arthritis and have no pain. I've seen people who are still running 10Ks that if you looked at their x-ray, they have no joint space left. Or I've seen individuals who have been having a really hard time walking down their hallway because their pain is so significant. So there's a lot of things that come into play, and based on the topic that we're talking about today around exercise and arthritis, one of the biggest things that I'm gonna say is that having enough strength around the joint is going to alleviate a lot of that pressure, and it's going to be one of the best ways that you can control the pain from arthritis or try to avoid things like joint replacement or things like that. With arthritis as an iceberg as well, the other variable is what we would call an inflammatory type of arthritis. So we have osteoarthritis is one of the main ones, you know, that wear and tear, and we'll talk about that. And then we also have inflammatory types of arthritis. So things like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and even a lot of individuals who are experiencing things like an autoimmune condition, even things like celiac or colitis or anything like that, can sometimes also have joint pain that's kind of in that arthritis family that is part of their condition. So there's kind of two big groups of arthritis. So what is it? So it's considered a joint disease. And it's the breakdown of cartilage around a joint, leading to a smaller cushion, which is why when you take an x-ray, instead of having potentially this much space, we may have this much space or this much space. And what is often met with is pain, swelling, and stiffness. Those are probably the three things that individuals with arthritis are going to be experiencing. Like even if it's inflammatory or if it's osteoarthritis. But it is like gray hair. So if you were to x-ray my spine, I would have some arthritis in my back. I don't have any pain in my back, but I do have some arthritis. That's okay. It's when we start experiencing pain from arthritis that we need to do something about it, which is why, just from a professional perspective, I'm pretty against doing preventative x-rays, because sometimes we can get worried about something that is just a normal part of getting older. And so as our population gets older, we're going to be seeing a lot of people who are dealing with arthritis. And the estimates from the Arthritis Society from 2017 or 2018 is that about 5 million Canadians have arthritis. So 1 in 6 are experiencing pain from arthritis, and that's probably, you know, so you are not alone when it comes to having pain from arthritis. There is a lot of people who are dealing with this right now. And so we want you to feel empowered that you know when your arthritis, for example, is flaring up on you, what are the things that you can do to help you immediately? And then what are some of the long-term solutions that we can give you so that if your goal is to avoid a joint replacement, or if you've had a joint replacement and you want to keep your new knee or new hip or new thumb or new shoulder as healthy as possible, what are the things that we can do? My slide changer has left me. So we have different types of arthritis, as I mentioned. So osteoarthritis is the most common one. It is the one that is around the wear and tear in the joint. And then rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis are in the inflammatory camp. So these are individuals who on blood tests would show an increase in inflammatory markers in different ways. Based on who is here, who is dealing primarily with osteoarthritis?
I still don't understand the difference.
Yeah, so osteoarthritis is joint specific. So wear and tear at your knee, for example, and it is only your knee that bothers you. Someone who has rheumatoid arthritis would have inflammation through their entire body and would have something called active joints. So, we'll talk about rheumatoid, like for example, the joints in the hands and feet will get sore. And they can have like I don't know if you've ever seen individuals who have their hands have like these bulbs. That's a very severe rheumatoid arthritis, or like a drift. So it's going to be more affecting your entire body rather than one specific joint. Yeah. And yeah.
I'm not sure.
Yeah. Have you ever had a blood test to give you a look at your inflammation in your body? Okay. Great. Yeah. Yeah.
Since the time I'm on Amazon, and we're trying to do the right now, so I'm just now other joints. That's why I'm here.
Yeah. So you would be in more the inflammatory camp. So there are probably about 20 different types of arthritis that would fall in this inflammatory camp. These are the 3 most common, but there are other conditions such as yours. Prednisone is a corticosteroid that tries to bring down the inflammation in your body, and that is an example of why the body would be attacking the joints and causing pain. We'll talk about that too. Yeah.
From broken bones in arthritis going around, which one would fall under?
Osteoarthritis. Yeah. For osteoarthritis, one of the biggest risk factors for the development of arthritis is a previous injury in that joint. Yes, which makes it very confusing, but yes, you can. Yeah. my people at home, they said, someone asked, can you have both osteoarthritis and a rheumatoid arthritis? And the answer is yes, which just makes it more confusing. All right, let's talk about osteoarthritis. So this is the degenerative type of arthritis. It is a wear and tear type. So an example, my husband, he played semi-professional football. He is broken. He has had multiple surgeries. I swear he married a physiotherapist on purpose, but he has had multiple reconstructions in his shoulders and his knees. He is more prone to having knee arthritis as he gets older. And the reason why is because he took a lot of impact and pounding through his joints, and that accumulation can lead to a predisposition to osteoarthritis. If you've ever heard somebody say that they have DDD or degenerative disc disease, that is an arthritis of the spine. I actually hate that term because it sounds brutal, but it really is just an arthritis. And so there's a lot that we can do for that. But even just the word degenerative, I think sounds, gives you like the, I don't know, like, oh, there must be something really wrong with me. And the same thing with stenosis. So stenosis in the back is a narrowing where the nerves are passing through to the lower body. And so if they are, the arthritis is causing a reduction in space, then that can make the space where the nerves come out smaller as well. We have our paint store beside us, so you're hearing them pounding on the paint cans. So what are some of the things that we can change about developing arthritis in general? One of the things that we can change is our body weight. So we know that individuals who are overweight or obese are more likely to have more force down on the joint, and it can accelerate some of the development of arthritis. Having not a lot of strength around the joint that has arthritis is probably one of the biggest things that are within our control. And this I see a lot in my clients who are retired, especially my retired men who come from trade jobs, right? I have a lot of my clients who were very active in their profession, so they were always really strong. And then when they retired, they still stayed active, but not nearly to the same level. And so they've lost a lot of strength in their legs, and now all of a sudden their joints are starting to hurt when they had it previously. And I put chronic conditions in both because we have a lot of chronic health issues that we can prevent through lifestyle factors, but there are also a lot of chronic conditions that we cannot, and there is a genetic component. So depending on what is going on, we have a lot of things that are in our control when it comes to even being diagnosed with these. Non-modifiable factors, unfortunately, we can't control our age. I wish. And we can't control if we've hurt our joint in the past. So an example is people used to think, and I think I have a slide about this, that running caused arthritis. Don't run, it's bad for your joints. That is absolutely not true. What we know is that individuals who are runners who have hurt their knee are more likely to develop arthritis later. But it's not the running itself. It's an athlete who's had an injury. Like I've seen so many men and women who were athletes when they were in university, and all of a sudden they're experiencing some arthritis later on.
Can't hear a thing.
Rheumatoid arthritis. So rheumatoid arthritis is probably one of the most common inflammatory types of arthritis. So this affects the whole body. You would have blood work done, and if they showed a rise in your rheumatoid factor and your CRF, so your C-reactive protein, CRP, which is an inflammatory marker, you would probably be referred to a rheumatologist in Kingston, and they would help manage. So prednisone is one of the ways that we try and bring down the inflammation. That's usually a snapshot in time to try not to keep people on prednisone for a long period of time because it has other issues. And then they would start giving you other tips and strategies or medications to bring down the amount of inflammation, and then you would work on the strengthening piece. So if you have an inflammatory type of arthritis, there's often a medication associated with your condition, whether you need to be on it all the time or not. And it is also something, oh, that's okay. Bernadette, if you can't hear me, we're going to do a recording of this as well. So you can send me an email and you'll be able to have a version there that you can listen to whenever you have the capacity to.
Thank you.
So the thing with the inflammatory types of arthritis is that you are usually going to be followed by a rheumatologist. And it usually affects the small joints. So individuals with rheumatoid arthritis experience pain in their hands, in their feet, in their wrists. They can experience stiffness in the morning, all of those types of things. It's usually diagnosed between 40 and 60, not always. There's juvenile forms of it as well. And one of the biggest things that's often not talked about when you have a rheumatoid arthritis is the fatigue aspect, which is extremely important when we're talking about movement, right? Because if we're having pain and we're also exhausted, trying to be super active and do all these things is extremely challenging. And so when I'm working with clients with these types of conditions, we are talking about the fatigue aspect as well. And how do we manage getting the movement that you need, but also respecting the fact that your body is feeling a little bit more run down, and talking about the fact that sometimes, even though it's counterintuitive, the more active you are, the less fatigue you experience from the condition. But it's that in-between where you have to get into that level of activity and into that routine before you start to see the effects of it. All right, risk factors. Again, what we know about having extra body weight on us is that it releases inflammatory markers. So level of inflammation in the body with extra weight, especially centrally, is that there's an increased level of inflammation in your body. Smoking also leads to systemic inflammation in your body. Not an easy thing to try and remove. Some of our foods can be inflammatory and some aspects of our environment. So I grew up in Hamilton, Ontario, and it's interesting because a lot of my friends who lived, the dichotomy is on mountain and I don't know if anyone knows Hamilton, but people who are by the steel plants, even some of like the toxins and stuff that they were breathing in, I think links to different inflammatory conditions. Whether or not we have the research to support that or not, that's anecdotal, but definitely some aspects of our environment, including the food that we eat and the air quality and things like that. It'll be interesting, even in California, my brother's in BC, with the air quality, with the fires and stuff, if it'll flare somebody up who has those types of conditions. Just like me geeking about it. Things that we can't change, our age. Being females are more likely to have rheumatoid arthritis than men. Flip that with ankylosing spondylitis, men are more likely to have it than women. So from an inflammation perspective, the extremities, our hands, feet, are more likely to be impacted by inflammation in women, and the spine is more likely to be affected in men. I have no idea why that's true, but it's pretty consistent. And there is a genetic component to rheumatoid arthritis that is obviously outside of our control. We can't choose our parents. So this is a picture of somebody with a very significant amount of RA. A lot of people actually don't get to this point anymore because of the different types of medications that we have and a little bit better detection system, so we can detect this type of arthritis very early. But this is what's called a drift, where the fingers, because of the arthritis, have shifted, and it can cause a lot of issues with things like grip, and it can be painful. It's kind of like essentially having like a really bad bunion through your whole hand. So if this is an individual who is experiencing rheumatoid arthritis, some of the medications, they're gonna start with a non-steroidal anti-inflammatory, like ibuprofen. Then they're gonna go to methotrexate. That's gonna be like kind of like the checklist, usually with rheumatoid arthritis. Methotrexate is hit or miss. I have some of my clients do really well on it. I have some of my clients who feel horribly nauseous on it. And so it doesn't last very long because they're like, I don't want to feel like I have the flu, well, especially with COVID, I don't want to feel like I have the flu. But they're like, I just can't get through my day because of the side effects. So it depends on the person. And then from there, they'll go into something called DMARDs. So disease modifying anti-rheumatic drugs. which are essentially a more active, more potent type of medication. But we want to try first line before we get into some of the other types of medications. And some of them, they're not always covered by OHIP. So you have to, in order to petition to OHIP that they cover some of these expenses or your insurance, you have to show that you've given the first lines of treatment a fair shot before they'll say, okay, like it was ineffective. Your doctor agrees that it was ineffective. We can go to the next type.
What about the Tylenol for arthritis? I mean, it's got whatever 625 milligrams or something that it says suited for arthritis. Tylenol, 3 different colors.
Yeah, I think that sometimes the packaging is it's the same active ingredients. So for Tylenol, it's going to be acetaminophen. For Advil, it's going to be ibuprofen. They're going to be slightly different. I'm not a pharmacist, so I can't really talk about the active ingredients. But do I think that, like, I don't think that there's that much difference between a Tylenol for cold and flu and a Tylenol for arthritis. But there are different types of, so Tylenol is actually not an anti-inflammatory. It works in a different way. Doesn't mean that it doesn't take the pain away, but it's why sometimes people will do combinations of Tylenol and ibuprofen, because they're not, but if you took like ibuprofen and naproxen, they're both in the same class. So you would be essentially overlapping what they're doing. So you have to just be careful about mixing those two. And again, I would be talking to your doctor about that, not to me. Or your pharmacist, who is a hugely underutilized resource in our healthcare system. They have so much information, probably more than your physician does in terms of the pathways and things. So I would definitely be talking to them. And then one of the other common non-steroidal anti-inflammatories is diclofenac, which you can take as an oral, but it's also the active ingredient in like Voltaren, like the smell, like the icy cool smell stuff that people put on their knees. You can smell the menthol almost immediately. But that's one of the more active ingredients. But again, I would talk to them about what the best course of pain management would be for you. My pain management wheelhouse is around movement. Yeah, so biologics is another class of medication that would be a DMARD. So again, it would be another one that once you've gone through methotrexate and some of the things like Plaquenil and some of these other medications, that you might try that as a last.
There's no.
That is a very good question. I am not sure. I'm sure that there are quite a few like naturopaths or holistic nutritionists in Kingston that would be able to help you around there. Supplements that I've heard have been helpful are things like magnesium. Some of the chronic pain physicians in Kingston have recommended it. But again, that's really outside of my scope, and I just try and stay kind of in my lane and refer out. Hugely.
But it's not just for the overweight, it's for example, all the night shift and
Yep. So some of the diet trends that have a lot of research for them is switching to things like the Mediterranean diet, because it's very high in fruits and vegetables. But diet trends come and go, but the biggest thing is trying to avoid as many processed foods as possible and seeing if you do have any sugar. It's interesting because I've heard a lot of my clients talk about nightshades. So they're a class of vegetable that has an active ingredient that some people find very irritating for their arthritis. I don't know what the research is on that. I haven't actually looked into it for several years. But if there's things that you can do by just eliminating something in your diet, then I would always go to that versus a medication just personally. But yeah, I'm like that too. So unless I absolutely need it, that's kind of mine. All right, ankylosing spondylitis. I don't think there's anyone in the group that has it, so we will go through it very slow or very quickly, not slowly. So if we think that rheumatoid arthritis affects the hands and the feet, ankylosing spondylitis affects the joints in our spine. So what can happen with advanced ankylosing spondylitis is a ton of restriction and the ability to turn. They will have a hard time even extending because it comes into some of the muscles in the hip. You can see I wouldn't even consider this advanced. I've seen like almost like completely locked in a forward flexed position with the requirement of a walker. But yeah, they call it essentially advanced ankylosing spondylitis will almost look like a fusion of the segments in your spine. But again, we're starting to look a lot more. We're diagnosing this a lot earlier. We're getting people into exercise programs that help to try and maintain their range of motion for as long as possible, and the quality of life for these individuals is getting a lot better. Because now that there's no space, have you ever seen a bamboo pole? Yeah, so it kind of looks like there's one segment that's hanging together like a bamboo pole. Yeah. Sometimes it's not the nicest, potentially. All right, psoriatic arthritis. So individuals who have psoriasis, some individuals can have an issue with their psoriasis which causes arthritis. So what we usually see with individuals with psoriasis is that you get symptoms in the nail and in the skin. 10 to 30% of individuals with psoriasis can start developing symptoms of arthritis from it. And it's usually diagnosed before 40 years old. Just another one of the types of inflammatory arthritis. Okay, what can we do about it? That's what you guys are here for, right? We want to see what we can do. So the way that I've kind of broken this up is that we have the short game and we got the long game. The short game is I played golf and I walked too much that time and all of a sudden my knee is on fire that night. What do we do? Versus I know I have arthritis in my spine. What are things that I can continue to do to make sure that my arthritis pain does not get worse or it gets better? One of the things I get asked a lot is, should I use ice or should I use heat? I say it does not matter. It does not matter. Because the reason why we use ice and heat is because it is a change in temperature. So temperature and pain go up the same track to the brain, and it competes with the pain signal. That's how it works. So especially for somebody who has an established arthritis, you are not going to be modifying swelling a ton. And even now for acute injuries, the research on using ice to reduce swelling is actually quite low, and they're encouraging people to elevate it about the heart more than using ice. The one thing that I will say, so it definitely is based on preference. Some people prefer ice, some people prefer heat. With ice, you will feel more stiff once you take the ice off. That's just because what happens when you're cold. That is okay. There's nothing wrong with that. But just so you know, you may feel a bit more stiff when you take the ice off. Pain medications, we talked a little bit about that. Another one that's coming up that I talk to my clients about a little bit, but I usually refer out, I just know that they take it, is CBD. There is still a ton of research that needs to be done about the use of CBD oils. There's different percentages of CBD versus THC. That is not, again, not my wheelhouse, but our preliminary research shows that sometimes individuals who use CBD are less likely to abuse opioids. So if we can use something like CBD to try and get us off some of those heavy duty drugs, but it's, again, based on preference. All right, these ones are going to be really, really important. So oftentimes what happens when pain from arthritis flares up, it's basically that you did too much for what your body was ready for. So that could be because of strength, that could be because of endurance, that can be around a lot of things. So say you do 5,000 steps in a day on average. And then you go on the weekend and you're out with family and you do 10,000. Your body may not have been ready to double up the number of steps. You may feel like, oh man, my knee is killing me, my hip is killing me. So one of the things that you can do is take a break or realize how much your body is ready for and then rest, which can be really, really hard to do. I am not a very good person at taking rest time. I'm not saying don't do anything. I'm saying, say you start to experience pain at 30 minutes. You do 30 minutes of gardening, you start to feel pain. So I'm gonna do 20 minutes, and then I'm gonna go inside and do something else. And then I'm gonna do 20 minutes so that you're staying under the pain threshold. So not doing nothing, oops. It's not doing nothing, it's staying under your pain threshold. And then as you get stronger, as you get more endurance, this pain threshold increases and you can do more and more things and stay under your pain threshold. But recognizing where that is and realizing that if you have a day where your pain is worse, that does not mean that there is more damage, that you have not made your arthritis worse. You have not increased or decreased the amount of joint space. It is just a signal that your body is telling you you have done too much that day. And that's a really important thing to consider because I have a lot of my clients who are very fearful of making their arthritis worse with movement. And we talk a lot about why we have pain in our body. And it's a lot around basically signaling when we're doing a bit too much. What about stretching? There is very little research on the use of stretching for long-term healing. What we do know is that stretching makes us feel good in the short term. Unless we are very dedicated, we don't usually tend to see a big change in our movement and mobility. We do see a big change in movement if we are now strong throughout our whole range. But I recommend it a lot for my clients if it allows them to just get that little tiny bit of movement, get the cobwebs out, especially if they have that stiffness in the morning. I give them a couple of things to go through just so that they feel a bit more ready for the day. Yeah, it is good for flexibility, but the amount that you would have to do as we get older is you have to hold every single stretch for about a minute. Just to have enough of a signal for it to change. I don't know very many people who will stay a minute in a stretch. Myself included. What I also see is that the research now is starting to show that there is a big benefit for dynamic stretching. So instead of like reaching down and hold, things like doing like scoops. And you see as much or a bigger change in length, even without big stretches. And it's because we're getting that warmth to the muscle. We're starting to allow it to have a little bit more freedom to move. And also I find that sometimes the reason why you can't reach overhead isn't because I can't get your joint there. If I was to do it for you, it's because your muscles aren't strong enough to go here to here. You don't do it enough. Yeah, so what breathing does is it changes you from like your fight or flight system to your rest and relax system. And so if you're kind of holding your breath, your body is primed for max effort, which is the opposite of what you want to do with stretching. Yoga is great for a lot of things like balance, stress management, just generally getting rid of tension. Usually, it depends on the type of program. Usually it doesn't hit the intensity for us to see changes in strength, which is really important for our heart to get stronger. Yeah. My husband and I, we're both strength athletes, so we definitely have a bias there. So my husband and I went to yoga once, and they told him, I forget what it was, but I think it was happy gait. Like, you know, where you grab your toes and you have your knees, and there's no way. So I see him like trying to like hook his leg up, and it wasn't the most graceful display of athleticism he's ever had. But anyways.
Big yoga, you use a lot of strength.
Oh, for sure. And the heat, the impact of the heat. Oh yeah, so yeah, it's so good. That is definitely a workout.
Yes.
And we're starting to see like a lot of different types of yoga come up. Like you're seeing like yoga fit type of workouts, which are like holding a lot of these poses that require a lot of effort and doing quick transitions and stuff, for sure. It's a great way to be active and just enjoy stuff like that. All right, ultrasound, acupuncture, and electrical stim. This has been the bread and butter of the physio profession for a really long time. And it's because short term, when you get off of the stim, it feels better. Unfortunately, that usually only lasts for about 20 or 30 minutes, similar to heat or ice. So it's a great way when you're flared up to be able to help with some of those symptoms. There's a little bit of benefit potentially for acute knee pain from arthritis. Again, that's short term. But what they think is that the waves and things of these machines block pain signals similar to temperature. So just in terms of my bias, and this is totally just my way, the research is supporting more movement-based. So you can get a 10 unit at Shoppers or at Amazon for $40 or $50. I would rather get you to do that at home after you've had your session with me, and I want to spend my time getting you moving, getting you doing more active things. So a lot of my clients who are seeing me for arthritis, whether they want to be or not, are in the gym with me. So we're doing a lot more active things, and that's just my bias. Okay, how about arthritis in the hands? This doesn't have nearly as, arthritis in the hands don't have nearly as much research. The reason why is because most of the muscles in our hands, the big bulk of them are actually in our forearm. So what happens is they attach in the forearm and swoop in slings. And by pulling through here, we start seeing some of those movements in our hands. So we don't have the same, like with the knee, we have these big muscle groups that cross over and support it. Here, they're tiny tendons. So there's a little bit of research for increasing your grip strength. In general, grip strength is important for living independently. How many women have trouble with jars? We have, for our barbells, we have these clips like this. And I make all my female clients try and do it, because they have to take them on and off, and it requires a certain amount of grip strength to be able to do that. So these they look like those old school grip trainers. Do you remember those? I don't even know if they're around anymore. Yeah. Are they? Yeah. So those grip trainers, I think it's important for us to maintain that strength. But usually the biggest thing that's going to help with stiffness is moist heat. So having a shower. If you're lucky enough to have a paraffin wax bath, I don't know if you guys have ever seen those, but they're like pure heaven. Some spas will have them and wrap you in paraffin wax after. You're just like, oh my goodness, this feels so good. That's the one thing that can really help. And then again, that work to rest ratio. If you're pulling weeds. I've just been thinking about my fall garden because it frosted last night, and I'm hoping that nothing is dead. But that's why I'm using gardening as an example, because I've been thinking about it and being like, oh no. But definitely what we can think about is that work to rest. Splints, sometimes people will recommend guards for at night for people with carpal tunnel and with rheumatoid arthritis, with the idea being just so that you don't curl your hands up the entire night in fists, and then when you wake up you feel really stiff trying to open them. The guards just kind of keep you in a more open position. Some people really like them. Some people hate them because they feel uncomfortable. Again, it's one of these things that the research is kind of still.
They really do work well when you're sleeping.
Yeah.
I have carpal tunnel.
Yeah.
For surgery. And when I went to see the specialist last November, it was taking forever to see a plastic surgeon, he said, wear the guards at night.
Yep.
He had it too, the physician, and you will see a huge difference.
Yeah.
And you do.
Yeah.
And then you're not moving around during the day. You just put them on. It keeps you from curling, because it literally does take a long time to.
Yes.
So I swear by them.
Yeah. And if you feel comfortable sleeping with them, some people just have a hard time sleeping with them. But the carpal tunnel comes through here, and so it's pinched. It can cause numbness into the hand. Most people complain more of numbness than pain, but both can be on board. And so if you're sleeping like this, you're essentially closing off that carpal tunnel all night. And so the idea is keep those guards on. It opens up that tunnel, allows the nerve to flow easily, and can reduce some of your symptoms.
I was reading one of those sponsored sites on Facebook, because I Google arthritis.
Yeah.
I get all these
Of course. Facebook is smart that way.
They were talking about compression salts. Like we have compression salts.
Yeah.
I think it's more for aspirin and arthritis. Yeah, it's just like saying that you can come up with, you burn it all day long in here. Just people say it has over 2,000 positive reviews.
Wow.
And they're saying it's just you feel more strength in your hands.
Yeah. Yeah, that's a really good question. So the question was around using compression gloves and compression braces. So it's really interesting because what the compression does is it's almost trying to stimulate what stronger grip muscles would do, right? Because with the knee, it just gives you that little bit of support just like your muscles would. So I like using it in the short term with my clients so that I can get them being more active. And I do not usually support these like $500, $600, $700 braces because there's just no research to support that they are better. So hold on. So my husband and I are competitive weightlifters. Ooh, these are still sweaty. I'm gonna hold it very gingerly. This is a basic $30 knee brace. I know, it's gross. So what they do is they just apply a little bit of compression. So I squat extremely heavy 3 to 4 times per week. So I do a lot of volume. And what the research has shown is that for injury prevention, this is not a rehab tool, it's an injury prevention tool. And so that would be the same thing for arthritis.
But is it better for osteoarthritis or osteoarthritis, or is it better for rheumatoid arthritis?
That's a good question. It would probably be equally as effective because it's the compression just gives a little bit of support to the joint. So I don't think there would be a difference between a rheumatoid arthritis or an osteoarthritis. The only thing that I would say is it depends on the amount of swelling that you get with rheumatoid arthritis. So if you get a lot of swelling, you just want to be careful that you aren't cutting off circulation to your hands, things like that. So if you're starting to see a change in color in your skin, if you're starting to feel pins and needles coming into your hands, if you're starting to feel like your hands are falling asleep, that probably means that there's too much compression and it's not getting enough of the blood circulation that you need.
You know, trigger fingers cause arthritis?
That is a good, I do not know.
So I had trigger finger and they ended up by injecting me with cortisone,
Mm-hmm.
and they last me not months, and it's been pretty good. It's a little sometimes it locks, but not like it used to.
Yeah. So trigger finger is usually because of a locking of the tendon, but I don't know if arthritis would predispose you to something like that. That's a good question. I'm not sure.
Okay.
Yeah. Okay. So the long game. Let's talk about surgery and lifestyle stuff. So when you start getting pain from arthritis, there's a couple of ways that you can go. You can go conservatively, which is obviously my bias because I'm a conservative therapist, where you would start with doing some physio stuff, and we'll talk about that after. But if you're in the medical system, the first thing that they will probably do is try and do something like a cortisone or a Synvis injection. So we're going to talk about those. So cortisone is often used for pain management. So what they would do is they would stick a rather large needle, I always warn my clients, it's going to look scary kind of, into the joint line. So the important part is that they have to localize the injection right into the joint, and there is a local anesthetic and a corticosteroid that they inject. And the cocktail that they use for the cortisone is different and it's changed, so I'm not really up to date with what they use. But they try and space out your cortisone injections because too much cortisone in high doses in the joint can affect the integrity of the muscle tendon and the bone around that joint. So just something to think about. What I like to do as a physical therapist, so I have a client going to get cortisone, is that is my window of opportunity. Your pain is down, let's strengthen that joint. We're gonna get that joint as strong as we possibly can. We have the cortisone there to help with, sometimes our biggest barrier is pain through specific ranges. That will be down a little bit, and so it's something that we can use to try and help us get your body stronger so that you don't need it. I've had clients did their first cortisone shot. We really strengthened her joint. After 7 or 8 months, she was getting a little bit of pain in her left knee, was thinking that she was just waiting for a replacement. And now she's been working out in the gym for 3.5 years. She can squat like 150 pounds. She's almost 70 now and is doing amazing. She's like my success story. And this is her. So, is a joint replacement inevitable? We oftentimes think that, we have arthritis, we're just trying to wait until we need a joint replacement, or you'll have a consult with the orthopedic surgeon and say, we want to kind of hold this off as long as we possibly can, which we totally agree, because we have probably about 15 or 20 years with a knee prosthetic, and then we might have to do a revision. So Anna, she was kind of my inspiration. She was in a wheelchair because of pain. So moderate to severe arthritis, degenerative meniscus issues in her knees. She worked at Zellers. If people remember Zellers. So she stood at her job, and they gave her a cortisone shot and said, go to physio. And what we did was a ton of strengthening. And it started very low level, and it's built since then. And she now is almost 70, is not really experiencing any pain in her knees, never needed a replacement, thank you. And she used to hit on my husband all the time. We were in the gym, she used to call him lover boy and stuff like that. So now not only did she remove the pain from arthritis, she became part of a community gym. And that gave her a big sense of, having that social belonging and being able to exercise with her. And so her husband joined too. He's now 75, and he just deadlifted 200 pounds for free on his 73rd birthday or something like that. It was pretty crazy. So you can get strong at every age. But what happened, and the big thing that I want you to take home of this workshop is that as your strength goes up, your pain will go down, because there's a lot more support around your joints. But when you're doing strength training, it has to be challenging. One of the biggest issues we see is that people are doing exercises that they could do 50 of, and they're doing 3 sets of 6, and then it's just not, they're like, I did those exercises. And I was like, no, those are not hard enough. Like, they have to be challenging. You have to get to the point where if we're doing a set of 8, that by 7 or 8, you're like, oh yeah, like I need to rest after that, because I need to regenerate my capacity. And that's probably the big, and one of the things that as a physio profession we need to fix, because sometimes we're the worst for that. So my TM, if I leave nothing else with our community as a physio, your body needs to be strong enough to handle what you're asking it to do. And unfortunately, as we get older, unless we are strength training, our strength goes down. And it will go down faster if we sit on our butts. So we need to be strong enough to handle what we're asking it to do. Because if we aren't strong enough, our pain increases. And so people ask me all the time, Christina, why do you get individuals lifting heavy weights? And here's my answer. If I have a client who is in her 70s and can lift 50 pounds off the ground, you'll think, oh, that's a lot. When she is lifting up her 15-pound bag of kitty litter, she is now working at 20, 25% of her capacity. If she is only lifting 15 pounds off the ground, and then she has to lift that 15-pound bag of cat litter up off the floor, she is now working at 100% of her effort. Have you ever worked at 100% effort? It's very tiring. You can't reproduce it very often, and it would require a large amount of rest to recover. So if we could increase your capacity, then you could lift cat litter all over the place. Probably don't want to, but for this example, you can reproduce that effort. And I call this 1 rep max lifting. So this is probably one of the biggest reasons why, well, it's one of the top 3 reasons why individuals no longer are able to stay in the home. Because they are starting to have falls, because their body isn't strong enough to get up from the toilet, which is a squat. They aren't able to roll over in bed, or they're starting to have issues. So the biggest reasons, the 3 reasons why people transition to a long-term care facility or nursing home: cognitive issues, incontinence issues, which is a whole other workshop, and strength. That's probably the big 3. And that can be because of different chronic conditions or not. So really, really, really important. And one of the things that helps is that what we know is that individuals who have inflammatory arthritis also are at increased risk for heart issues. So we can see individuals with a bit more of a laundry list of medications, with blood pressure meds and cholesterol meds. So all of the things that we're doing to improve your strength are also going to make your heart stronger, which is just, I love those big bang for your buck type of programs. So this is why our model is around increasing your strength. Because I want to increase the amount of reserve that your body has. So that the day-to-day tasks that you are doing, whatever they are, whatever you want to be able to do, that you have a lot of reserve to do those. That the thought of going out for a hike with your child for 2 or 3 kilometers isn't like, oh my gosh, can I do that? I don't know if I'm gonna be able to do that. Am I gonna be exhausted for 3 days? All those types of things. If you want to babysit your grandkids and they knock you out for a week afterwards, like, can we build your capacity? Can we build your endurance so that you are not in pain after picking up your grandchild? We had a member who's now been with us for 2.5, 3 years, not for physio, but for general, who had back pain every single day. She would be on a heating pad at night, and it was because her grandson, who was 30 pounds, she would take care of him every day before school or before daycare of her son's work schedule. And so when she would be lifting him, she wouldn't have the strength to do it. So her back hurt every day. It was like this magical threshold. When she could deadlift 35 pounds, so a little bit more than he weighed, for a set of 6 or 8, her back went away. And it's because she was now able to do it. Her body had the strength. And so she wasn't relying on her joints. She had the muscle capacity to do it. So it's really important. Because what tends to happen, and it's going to be interesting with COVID for individuals who have had COVID, because there's a lot of research coming out around heart injury and stroke. Like, I could geek out about this all day, but something happens. So it could be that you got sick. It could be that you had a flare-up. When we are in pain, our body protects ourselves, and we feel gradually weaker. Like, you've had a time where you felt sick. Do you feel as strong as you usually do? No. So what happens is you start to feel tired, so you rest more, then you lose strength, you feel more tired, you do less, you feel even weaker, and this spiral starts. And my life goal is to stop this spiral. And so I see a lot of people post-hospitalization as well, because you get a lot of deconditioning because you don't really move a lot when you're in the hospital. We just don't have the resources to get you up and moving as much, and you're feeling cruddy, so you don't really want to move. But we need to try and break this when we get back and out of hospital. So this negative spiral, we need to stop it. And oftentimes we can do that by starting to put the programs and the steps in place because of us being triggered by pain. Pain is a very strong motivator. We want to get out of pain, so it can be a great way to start jump-starting us to be just a little bit more active, feel a little bit more confident in how we can be active and not flare our joints up. Probably the biggest thing that I do is allow people to realize where their joints are able to go and what strengthening they're able to do so that they don't have pain after going to the gym or after going for a walk or those types of things, because there's nothing that's going to kill your motivation more than going to feel like I went to the gym and my joints hurt for like 6 days after. And then you just don't want to go back. And then the other thing that happens is when you're not moving, you're like, I'm just going to go and have a snack and watch a movie. And what can happen there is that we get into the cycle where we're not exerting as much energy and we aren't modifying our diet for the decreased intake, right? So if you're having 2,000 calories a day, but you're active, you're moving around, even with COVID, we're walking from place to place. And then we go into the house, like people are talking about the COVID-19. But oftentimes, not only was there an increase in our food intake, or even if it was steady, our activity dropped pretty significantly. And then we can get into that spiral of adding a bit more weight. And so speaking to the arthritis and nutrition piece, what we know is that individuals with things like celiac disease are more likely to have inflammatory rheumatoid arthritis. And that's because of just general inflammation throughout our body. And we're starting to see a lot of cool research coming out that, again, I think this is fascinating because it puts the onus of control on me. I'm not relying on waiting 6 months for a physician to tell me what medication to take. I maybe will get there, and I think that's great, and that might be the necessary steps, but I know that I can modify my pain with temperature. I can modify my pain with movement. I can modify my pain with nutrition. I have these tools, but I don't feel like I'm helplessly waiting for for something, especially like right now with COVID-19, our system is bogged down. We have a lot we have a big line for seeing physicians, and I feel bad for the physicians because they have a big wait list as well, which leads to a lot of frustration that is outside of their control. But we do have a lot of research to start supporting this, which is really cool. And the other thing with gut microbiota is like the bacteria in our gut. Somebody was talking to me about, I wonder what's going to happen with all the disinfecting, because all of a sudden that's going to change the cultures in our stomach. And I wonder if that's going to create more sensitivities to things. It's really interesting because we're starting to see a lot of research around that. But again, that's just me being nerdy. Okay, so we do know that risk of knee arthritis increases 5-fold if you're considered overweight or obese. So it is an important component. But when we eat too much, we gain weight. Okay. We can talk about this. All right, so let's do the exercise demo. So let's finish off. Does anybody have any questions about this? And if not, we're gonna do in our bubbles. We're gonna do a bit of exercise where we're at.
It's not one question. There's such a truth to magnetic, like magnets helps with arthritis. I just heard that a few weeks ago.
That's a really good question. So there was a really good marketing campaign that talks about those Q-ray bracelets that come on or magnets. I have not seen any research to support that. But there is a really strong connection between you believing that something is helping you and it actually helping you. There's also a really strong connection between you liking who is helping you and you getting better. So I think feeling empowered and feeling like there's something within your control is probably the biggest modifier. Because they were asking about those magnetic bracelets, and I was saying there's not really a ton of research to support those, but you know, having something in our control is something that can be really beneficial. Yeah. Yes. There is Nick there actually. We ran out of toilet paper. Nick, it's already there. That's already there. Sorry about that. We just realized at like 9:30 that we ran out of toilet paper. Does anybody else have any other questions? No? Excellent. All right, so we're gonna do some exercise demos at home. So we can't kind of pull your leg to try and get you guys to do them, but I really encourage you to try them with us. I'm gonna put this into gallery mode after we do the demo so that I can see you if you wanna turn your webcam on and we can kind of do a quick form check. We're gonna focus a bit more on the lower body, kind of hips, knees, low back. We're gonna do one technique that is my physio magic trick that I'm gonna impart on you all. And then the other, we're gonna do two big strengthening exercises for the lower body. Okay, so my physio magic trick. Oftentimes, people will say, I have no idea what I did, but my knee is now killing me. And they're like, they go through and they're trying to find this trigger, and they have arthritis and they think, well, maybe it's just getting worse. But oftentimes what can happen is you can get a tightness in the front of your knee and your big quad muscle comes across your kneecap and attaches right here on the base of the shin. So people will tell me that they have pain kind of either globally around the front of the knee, or they'll sometimes point to right here or right here. So if that is you, here is my physio magic trick for you all. So right now, my husband has a barbell on him. Of course, yeah. At home, this is using a rolling pin. Everyone's like, I haven't used, somebody in my class like, I haven't used one of those in forever. But what he's doing is he's rolling the bar up and down his leg. You're gonna find a couple of like trigger points or that you're gonna have to work through a little bit. It's gonna feel a bit uncomfortable, but it shouldn't reproduce your knee pain. And it's one of the things that after a minute or two can almost instantly change your knee pain. So we're gonna give that a try. So for individuals who are here, how are you with getting up and off the floor? Yeah, are you okay? Are you okay getting up and off the floor? No? Okay, so I'm gonna give you a seated option. And for everyone else that's here, we're gonna give you a barbell and for my peeps at home, I want you to try and go get a rolling pin and try that out. We're gonna try that for 2 or 3 minutes.
So these bars are different weights. So obviously the more weight, the more pressure is going to be on your leg. So when you start, I say start light. So these red bars here are 35 pounds. The blue ones are 45. Right? So start light and gradually add pressure as you go. Try not to drop it on your leg to start and see how it feels. Okay?
So,
Yeah, one more.
Who has knee pain? Intermittent?
And I just started this summer, I've never had anything ever before, and I went just to the other one, it's like, oh, what just happened?
Right, right.
Bad.
Usually it's like the straw that broke the camel's back. It's more, it's never that, you know, you dance, unless there was like obviously like a break or something. But I get, my favorite is when I get these like big guys that come in and it's like, I was putting my sock on and I threw my back out. And they're like these heavy weightlifters. I'm like, let's take a look at your mechanics. Okay, let's get you on the floor. Get you to try it. Yes, you're gonna come on your back. Your legs out.
All this stuff with the charcoal, things that we found by accident.
No, we're not. We're just gonna get you probably. You're just gonna roll this up. Yeah.
I'm just gonna roll it like this.
Yeah, exactly. We tend to, in our medical system, I think we try to hold on a little bit tight.
And then when there's
Okay, so I have been dealing with a wrist injury for the last 6 months, and I'm a weightlifter. So I lift heavy weights over my head and rely very heavily on my wrist. And for my job, I rely on my wrist. I got an X-ray. That sounds brutal, but I thought I might have a stress fracture. So I was like, let's just get a wrist stuff. It was negative, and then they got me an MRI. And I knew I needed it because I felt like there was a cyst in my wrist, which there is now, and I have to get it removed. But I was so afraid because I know that they will find something. I was a cheerleader in high school and university. Like, I've been doing a lot. Like, I work with my hands all the time. And I was like, I know my pain is not because of any sort of ligament damage, but I was afraid of having some sort of label and then getting into my head. And then I was like, oh no, like I have this and this wrong with me when really like I need to work on my grip, or I need to work on this, or I need to work on this. So it's sometimes it's our fault in the medical system because you say, oh, you have bone-on-bone arthritis. Like, of course you can't do this and that. And that is the opposite of helpful, and it is not even true. So, pardon? It feels amazing, right? Oh yeah.
that's the quote, it does hurt, right?
The two spots that you'll probably feel the most amount of discomfort is kind of the middle of the thigh where your hip flexor is, and right before the kneecap where the tendon starts for the thigh in front of the knee.
35 pounds. It probably feels like a lot more.
Yeah.
All right, if you guys used it on your sore knee, I like you to take it off and move it around and see how it feels. Right? My physio magic trick. Yeah. Something that you can do at home. Right?
With the demo roller, if you don't have to.
Double, yeah. Rolling pin, but you need to put pressure. This is something that if you're having a flare up, it works wonderfully. Yeah, foam roller too. For a lot of my clients, they just don't have the strength because you have to go onto your belly and kind of prop yourself up. So this is a way to do it without having to rely on upper body strength. Okay, the next two exercises we're gonna go over is the squat and the deadlift. So basically getting up from a chair and bending over to pick something up. Those are probably the two ways where a lot of people are feeling a bit more pain. So getting up from a chair can cause a lot of pain. When I see a lot of people with arthritis, they do exactly what you do. They shoot their knees really, really far forward, and eventually their ankles can't move anymore, and it goes where it hits underneath the kneecap, and people say, ow. So what we want to think about doing is bringing our hips and knees back at the same time. So when you get here, if you don't have any knee or your ankles can't go anymore, then you have to either come up onto your toes, which puts a lot of pressure on the front of the knee, or you just can't go any further and it's painful. So by bringing your hips back, it allows you to reduce a lot of pressure on the knee and distributes it across the knee and the hip.
But when you used to, I used to do squats and they tell you don't go forward over the knee.
Which is completely false. You can absolutely go past your toes.
Really?
So it's more about keeping your feet flat.
Yeah.
Right? So people said don't go knees over your toes because people would do this. They get onto kind of the balls of their feet, which does, as soon as your heels come up off the ground, it does put a lot more force through your patella and your quad. Now, if your feet stay flat, it's totally fine to be here. I don't have a ton of ankle flexibility. Like you can watch Christina, she's got more than I do. Her feet are flat, knees come way forward, no pain. But her feet are flat. If you don't have that same mobility, or like I don't in my ankles, my butt goes a little bit further back. My feet usually tend to be a bit wider too.
So we're just supposed to sit down in our chair?
Yeah, so right now what you're doing is, so the biggest thing for the squat is that, yeah, you want your knees to be over your second toe. Especially for a lot of my women, we tend to have a little bit of weakness through our hips because our pelvis is wider than men's. So I see a lot of this, which can cause, especially if your knee pain tends to be more in the inside part of your knee. So you want to think knees are out over your toes. Good. And then another thing that came up a lot around squats is that your toes always have to be forward. That is also not true. It's the position of your toes relative to your knees. So if you are out like this and your knees are coming forward, that's gonna potentially be painful. But if your knees are out here and your toes are out here, that is totally fine. So for my people watching at home, so we don't want to be like Elvis. We want to be like a cowboy. Think like a cowboy.
So like it doesn't really matter how wide you can squat as long as your knees can go out over your toes.
Yeah, you're a ballerina and you can turn it out.
So you basically, you're saying focus on here,
Yes.
not your knees.
Right? That was
Yeah.
much better.
Oh, it's much better. Good. Good. Yeah, and it's gonna depend on your body, right? Like I tend to have a much more narrow squat position than Nick does. Neither is wrong. It's just what works for your body and what flexibility you have in your hips, knees, and ankles. And so, yeah, it's totally fine. And you're also gonna see like people who are really long torsoed or have really short legs, if their squats are gonna look different. It's okay if you have a bit of variability. The biggest thing, yeah, is knees go past your toes. You're trying to go as low as you can. Again, that you can't squat below parallel.
Christina and I, top of my hip is here, top of hers is here. But our torsos are pretty much the same size. My legs are just a lot longer, so I end up being a lot wider because now my knees have to travel further than hers does, just because my legs are a lot longer. Right? Like I look at you now, you have fairly long legs proportional to your body. So you'll be a person who tends to be a little bit wider with their squat and a little bit more forward, which is totally fine. It's just kind of, it's proportional to what you want.
All right, here's the physio magic tip number 2. Sometimes people will shift too far forward or have a lot of trouble with the squat because of balance. And we can actually use weight to fix it. So when you are squatting, if you bring the weight a little bit out in front of you, it'll counteract your weight and it'll allow you to keep your chest up a little bit more as you go down in the squat. We're gonna give that a try.
Is it bad like to stand and block your weight?
It depends. If you forcefully, aggressively lock your legs out, it can be because it can force a little bit too much into the knee. And it depends on if you're hyperextending yourself. If you see people standing, like standing here with long legs is totally fine. If you have a lot of flexibility, like actually hyperextend, you do want to avoid it. You don't have to stand here with that knee. Straight is totally fine, as long as you're not
Right side, so the left
pushing
side.
back. You know what I mean?
Yeah, and that's what I do a lot.
Yeah, try to stand perfectly straight. You don't have to stand like that each is still with
And
your.
they're up. Right side.
But just
It's not,
you can
not
totally
not
straight
yet.
legs are totally fine. You just
Still
don't want to.
elevated.
Well, I just actual like almost squeeze their quads, that would be a little bit much.
So that's fun.
Yeah.
And she's sad.
Yep.
And you know,
For sure.
you have a side that you try to keep your.
I don't think so, that's not how it's lost, my last year. Depending on how I try to be a little relaxed.
Yeah.
Just not try that because things go down.
I know.
Do that.
Like,
Yeah, because
I
it
really
is.
don't need that. Yeah, don't get touched. Yeah.
So people like that before.
I
I
don't-
don't.
I just want to look. And now
Shut off. They don't do it. So it's 10, we think it's 9,
I'm on my all night.
it's when it's tight, the pull on is restricted.
So yeah, it's just.
Right underneath, like,
Yeah. Literally, you think like it's like walking to the rock.
It's usually weird.
Yeah, and then once I get moving, I'm okay. But it's just, and then like, I even feel like I'm rotating. Yeah, but it's true, it's like, it's like, you're asking, like, well, what's wrong? You start seeing strength issues with this, and I feel like sometimes it's not your elbow, but and then I barely left, and I don't know, and this is the thing, right? The hyperparathyroidism.
Yeah, this honestly,
It's
a couple of times a week, couple times, you'll take a lot of pain away.
Well, the other thing that's hard too is that when COVID, people didn't have weights at home. So they're doing a lot of endurance stuff, and they haven't been doing this, like the true strength training stuff. And so they lost a lot of strength. Like the reason why I think that the gym people say, especially like these two, I don't bias, but we can control this a lot more.
Yes.
And so I think it's super important.
And now some gyms are actually sending their trainers to your house, obviously bringing it with them.
Exactly. Okay, so last exercise that we're gonna do today. So for the squat, biggest thing is making sure that you're doing the movement correctly and then adding some weight to it. You should probably be in the 5 to 8 rep range. And so if you can do 10 or 12 reps at that weight, it is too light. Boost it. Boost it up. Okay, so the last one we're gonna go over is called the deadlift. It's a hip hinge. Many people, especially with arthritis in their back, are afraid to lift things up off the floor. Especially if you've had really acute low back pain in the past. It can be a big fear to have to overcome to be able to lift something up off the floor. But it's extremely important because we do it all the time. So we teach this like as soon as we possibly can for anybody with arthritis in the lower body or issues with their back. So Nick is coming very close to whatever he is lifting. We're lifting a barbell, but this could be laundry basket, this could be whatever you were trying to pick up off the floor. He's gonna bring his hips straight back. If you look at his knees, which is gonna be hard to see on the camera, but he's only bending his knees like 20 or 30 degrees. This is not a big hip bend. His back is staying straight. So hips, back, head, pretty much a straight line. You do not want to look like a dog pooping. Yeah, back is straight. And this is overextended, barely. He doesn't have the flexibility to overextend. But you're gonna imagine that this is an overextended arch. So then what he's gonna do is he's gonna take the bar and he's gonna bring it nice and close to his body and stand up. So if you're looking at, there is very little space between what he is picking up and his body. Imagine, I always use a case of beer. Would you hold a case of beer here or out here? It is much harder to carry it further away. That is true for anything that you lift up off the floor. Keep it nice and close, come in, and come back down. How we modify this for physio is that if you are unable, because of stiffness, which comes in with arthritis, see how these parallettes are here? We raise this up to a level that you keep a straight back, we strengthen there, and then we work on your flexibility, get you lower. So that's how we do this. The other thing that I see a lot of my clients do is they use their arms because they don't trust their legs. They try and hook it up with their arms. Our legs should be much stronger than our arms are. But if you've had an injury in your lower body for a long period of time, you will feel more comfortable with your arms, right? How many of your friends or your parents or whoever have had to rely a lot on using their hands to get them up or not off the ground here, or they rely on doing this, pushing with their hands. And that's usually just a sign of weakness. All right, so we are gonna try that with kettlebells instead.
No, we're not gonna kick it off.
And everyone's gonna start on their chair. So, with the chair, so if you were doing this at home, you can grab a laundry basket, you can grab a sack of potatoes or flour or anything like that to try and get a little bit of weight if you don't have any barbells, kettlebells, or anything like that at home. If you are doing this, right now we're doing this with a chair. So, next you can. This is his first video presentation. So, what he's doing is he's bringing his toes underneath the chair. That makes sure, one, that your knees don't travel too far forward, but it also means that he is nice and close to whatever he's lifting up. And then, so even more forward, I want your knees to be touching that chair. Yep, good. And then you're gonna bring the weight close to the edge. Yep, and then you stand up. Yeah. Good. No, it doesn't mean that you're necessarily doing something wrong. You're keeping it really far away, so you're probably putting a lot of strain on the muscles in your low back. So I would bring it nice and close to you.
You have a tendency to move a lot more through your kind of low back. I want you to think about your hip is the hinge. Right, so I'm bending on my waist, so even now you're kind of there. Right, so you want to think your hinge is your hip, not your mid and low back. Right, so the biggest difference is the first thing everyone always does is they go pick it up and they lift with their low back, then their legs. You want to think your hip is all that should bend here. Right, so my hip, my back stays flat, nice and straight, then hips forward. And back. Exactly. Right, so you just want to think, what I tell people is imagine there's a line coming out of, like, my pelvis is a bowl of water. If I do it, most people do is they overextend their back, I pour water out the front. If I tuck my butt underneath, I pour water out the back. If this stays perfectly parallel with each other, everything moves together, I'm not spilling any water, it means I'm also not either flexing or arching my back. So many people are so worried about arching their back because they've always told them, do that, don't do that, don't do that, but they actually end up overextending. They do like, I can't even do it. They do this like, you've seen the Queen's Girl. Right? That is just as bad as flexion. It's just the opposite direction.
Yeah.
Yes.
Oh, yeah, absolutely.
Yes, exactly.
Yeah. The core is for
stability.
stability.
Is not like everyone thinks your core is like just your six-pack muscles. Your core is basically a box from your sternum to the top of your pelvis, and everything, and it wraps all the way around. So like your core is your abdominals, which is here, your obliques, which kind of go around the side, and then you have your erectors and a bunch of big muscles in the middle. Right? So basically it's a big box all the way around, and that needs to be nice and strong. And while it is designed to move, it should move as little as possible.
With this movement.
With this movement.
Yeah.
There are other things where
You're gonna be
your
moving
back
through.
is meant to flex.
Yeah.
But
This one we're gonna
this
try.
movement, as flat and as tight and as strong as possible.
All right, give that a couple more tries. And then if you want, from the top, you can take a step back and try and go a little lower if the chair is a little low. Yeah, don't use, yeah, try and go a little bit more towards the ground. Yeah, beautiful. So you should be aiming for like the middle of the arch of your foot as you're coming down. So you're coming a little bit towards your toes, bring it back a little bit more towards you. Yes. Yeah, very good.
That's good. So do you have gym like classes too? Is that what
Yeah, we do. So we have
all of that.
we have like gym programs, physio gym programs, and physio programs. So we kind of have the whole gamut. So we have our general exercise program here at the gym, which runs throughout the day. We have our Conquer program, which is a kind of an arthritis specific group. And then we have our physio one-on-one, which we bias a lot towards. Yeah. It just means that probably where your body is seeing a little bit less strength is in that area.
And the other thing you tell people who get really worried about, say they deadlift or they've done pivot or something like that, my back hurts.
But some of
Where
it's
do you
just
feel it?
weakness.
And they usually go, I feel like there's two muscles running up and down my back. I feel it there. Those are muscles. They're the same as like if you did some bicep curls or anything and they're sore, right? So people get really worried, especially when it's their back, like I'm in pain. What type of pain is? Is it muscle soreness? Muscle soreness is good. Your back is a muscle. The same as anything else is. It needs to be strong, right? So it's trying to
Figure out good
disassociate
pain and bad
pain and back pain. Right? Because people get really, really worried about it. And rightfully so. If you've ever thrown your back out, you know how
debilitating it can be. Yeah, I teach around these concepts all over Canada, the US, and clinics and companies bring me in. Not lately, obviously, but I'm around a lot more. But I teach with a guy from Kentucky, and he was working in a nursing home facility. And this is just a funny story to finish off with. He was going in and he was working with this lady, and it was the first time she had really squatted weights, and he was doing all these things and getting her stronger, and he was so pumped. He's like, she did so well today. I'm so excited. She's got so much capacity to get better. Goes home. Next day, he comes back and is like, where is Mrs. So-and-so? And she's like, she's in the hospital. And he's like, oh my goodness, what did I do? Why is she in the hospital? Da, 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 da. She was starting to experience diffuse pain across the front of her thighs that was getting progressively worse throughout the day. Anybody who's ever worked out, that is what we call delayed onset muscle soreness from exercise. But she thought that she had a blood clot in her legs. And it was because he didn't explain that, you might feel like that kind of, I say it hurts so good, some people disagree with me, that diffuse pain in the front of your legs 24 to 48 hours after you do strengthening exercises that are not bad at all. It's actually just a signal that you did a lot of work and that your muscles are getting stronger. So setting up the expectation is extremely important. We say that to all of our physios, make sure that you say, you could have some good muscle soreness the next day.
That's a great one.
All right, does anybody have any last questions before we break for today? Yeah, so we've just been recording this session. So if you send us an email, we can send that recording to you. Yeah. Yes. Yep.
He's ex-military.
Yep.
Paratrooper infantry.
My uncle was like that too. Yeah. So for sure, yeah, just send us an email and we can send you the recording. Yeah. Anybody else have any other questions? All of these exercises relate directly to hip arthritis as well. Yeah. I'm totally for big bang for your buck exercises. So I tend to do a lot of general lower body strengthening within the ranges of motion and the weights that your body's capable of. Yeah, you're welcome. You're welcome. If you guys are interested in any of our physio or gym services, just let us know. Otherwise, I hope you enjoyed the session. I thank you so much for coming. I know our world is tumultuous right now. So we were really excited that we can have a small group and still try and do these workshops. We really enjoy doing them. And so if you have any other personal questions that you want to ask that you don't kind of want to do in a big forum, let me know. Otherwise, enjoy the rest of your weekend.
Yeah, no problem.
Bye, everyone.
Yes.
Well, and Saturday morning.
Thank you. It was